Спасибо. Good day. Our topic is multiple and associated injury. It's polytrauma. Polytrauma included three types trauma. It's multiple trauma, associated trauma, and combined trauma. The organizations of help in polytrauma now not have one tactics on all world. Different country, different hospital have different tactics. Have many definitions. It's polytrauma center. The countries of the Community of Independent States, it's hospital of emergency aid. In United States of America and England, traumatological centers. German, Switzerland, England, clinical and chirurgy. On Poland, clinical of surgical injuries. On Russian, больница скорой медицинской помощи. The state now definitions. Multiple trauma. Multiple trauma, it's two and more injuries with one cavity or a system. Two and more injuries with one cavity or a system. For example, you look, it's woman after automobile accidents. You look, on one moment have fracture both thigh, fracture leg, fracture bone on foot. It's many damage on one system. What systems? It's locomotor system. Next definitions. Associated trauma. It's simultaneous injuries of two cavity or injuries of internal organs and the segment of locomotor system. Associated trauma. Simultaneous injuries of two cavities or injuries of internal organs and the segment of locomotor system. For example, look, it's patients after automobile accidents. He have two damage. First, close trauma of abdominal organs with rupture, its digestive tract, and fracture of pelvic, its locomotor system. Typical trauma to system. You look, first moments have stabilizations, fracture of pelvic. You look, extrafocal device. And now patient have secondary moment of operative treatment on abdominal cavity. How many cavity have patients? 5 cavity. It's cavity skull, thoracic cavity, abdominal cavity, and retroperitoneal space for typical cavity. Associated trauma, it's more severe conditions of patients with dominant craniocerebral injury, presenting about 40% of all cases. Lethality composed 20-30 in this case. Combined trauma, it's different. One professor included its types of damage on polytrauma. As I said, it's not typical polytrauma. Why? Now I set you definitions. First, it's injuries due to the effect of different damage factors. It's very important. It's not how many damage. It's very important how many damage factors. How many may be damage factor? It's mechanical, thermal, radioactive, chemical, and others. For example, you look, it's patients after explosive trauma. You look, how many damage factors after explosive? 2. First, it's mechanical traumatic valve. You look, it's rupture extremity. On next side, it's open fracture. And thermal, you look, burns both extremity peroneus region. It's typical combined trauma, two and more damage factors, mechanical damage and thermal. It's slide very interesting. Why? Look, what arrest of bleeding. Put forceps on arteries for arrest of bleeding. It's and positive and negative side. Positive side, not have ischemia as a soft tissue. Why? Have collaterals. But if you put forceps on arteries for arrest of bleeding, its patients not can transport to other place, only lie on one positions. Traumatic disease. If patient have polytrauma, obligatory start traumatic disease. It's pathological process caused by severe trauma and manifested by characteristic syndrome and complications. First, obligatory. If patient have traumatic disease, start traumatic shock. Have many definitions traumatic shock, or a very short or a very largest for many page. Our chair very like its definitions. It's syndrome of hypercirculations with disturbance of tissue perfusion, developed in response to mechanical injury and other pathological effects, and their complications with result in decompensations of vitally important functions. Its definitions traumatic shock. Key moment of shock is hyperperfusions and hypoxia which define the following metabolic disorders. Coagulations blood system and immunological status. Nitrogen oxide formed as a result of activations of cytokinins and endothelium cause pathological widening of the vessels. Decentralizations of circulations and that contribute to irreversible of shock. The main pathological mechanism of traumatic shock. It's four mechanisms. First, afferent or a painful nociceptive impulsations, not present pain shock. If patients have only pain, patients not have traumatic shock. It's only key moment start shock. Next key moment, it's hypovolemia due to acute blood loss. Why? If patient have close trauma, patient have and blood loss. For example, if patient have fracture thigh, patient lose 1 liter of blood. If patient have fracture arm, patient have blood loss 500 milliliters. If patient have fracture ribs, it's 20-40 milliliters blood loss and other. Next, endogenical toxemia. Endogenical toxemia, it's not post zone. It's have 4 rod start endogenical toxemia. First, chemical. If patient have shock, not normal levels pass of oxygen, and what have chemical process without oxygen. If without oxygen, produce many toxin. It's first start endogenical toxemia. Next, if patient have necrosed tissue, absorptions, it's boson, it's secondary rod. It's absorptions toxemia. Rod number 3, start endogenical toxemia. It's retentions. Why? Not normal functions, kidney and liver. If not normal its organs, have endogenical toxemia. And last road start endogenical toxemia, it's infections. If patient have inflammatory, Pathological microorganisms produce toxin and start endogenic toxemia. On initial step, have maybe one moments or a chemical or a absorptions or a retentions or inflammatory, but if not treatment shock, obligatory increase and plus 1, 2, 3 and maybe 4 all road. And next key moment start of shock is polyorganic insufficiency. Syndrome of mutual aggravations. Injuries of one locations intensify the severity of the other one. General severity of the cause of traumatic disease due to the number of traumas increase, not in arithmetical progressions, but in geometrical one. Severity of polytrauma have three types. We look, green color. It's undangerous to life. Traumas do not present the danger to patient's life. Yellow, dangerous to life. Traumas are injuries of vitally important organs and systems which may be eliminated. And you look red, it's fatal traumas, means destructions of vitally important organs and systems which cannot be restored. Its patients die only on accident place or on first days after trauma. On accident place, not put final diagnosis. On accident place, if patient have polytrauma, correctly put diagnose damage head, damage neck, damage abdominal, pelvic, spine, upper and lower extremity. Not put correctly full diagnose. Why? Enough you lose time. You must have time for treatment patients on its period. Next, the period of development of traumatic disease. According to Roginski, 1982. Acute period. It's traumatic shock, included and post-hemorrhagical anemia, the syndrome of mutual aggravations. How long time? 1 week. Next period, the period of early acute bioinflammatory and necrotic complications. How long time? 2-3 weeks. And final period of traumatic results, late bioinflammatory and dystrophic complications. Without order and correct administrations, there is no the use from a great number of doctors. It said Nikolai Ivanovich Pirogov. Lethality in road transport accidents in the country composed 16%. The main reason of death in traumas is acute blood loss and traumatic shock. Lethality in traumatic shock composed 30–40%. In 20% of all cases, death occurs at place of accidents. In case of critical hypertensions, not more than 1 hour's durations, lethality composed 19%. If 3 hours, 35%. Hour over 3 hours, 88%. After its investigations on 17 years plus centuries, on United States stated on surgery Associative introduced thermal gold time. Gold time its first hours after trauma. On 18 years introduce new definitions, brilliant times, and its first 15 minutes after trauma. It's very important if very fast start first medical aids. Traumatic shock more often develops in polytrauma. Standard of doctor's activity. To fix the time of accident and type of ambulance arrival to the place of accidents. To eliminate panic and organize self and mutual help among people. To establish and support the contact with ambulance stations controller. To determine the number of victims and the main character of traumas. To start classifying and rendering the first aid in process of dangerous to life conditions. To determine the order of work of ambulance brigade arrived to accident place. To organize interactions with requires Ministry of Internal Affairs, Road Transport Self, Fire Brigade and military forces. To fill in medical documents. It's very, very important fill medical documents. Why? If you introduce narcotics and admitted patients to the hospital, another hospital don't know it's trauma of brain or introduce analgesics. Or if you introduce narcotics, patients maybe not have complaint on pain on abdominal. Next, algorithm of examinations of injuries persons at accident place. First, revisions of oral cavity and the upper respiratory tract. Evaluations of the rate and character of breathing, determinations of indications of artificial lung ventilations. Evaluations of hemodynamics, pulse, arterial pressure, shock index. Next, evaluations of neurological status. 4. Examinations of external injuries, colorimetry of traumas. Algorithm of examinations of injuries person at accident place. First, evaluations of respiratory system. Clinical symptoms of acute respiratory insufficiency and indications of for artificial lung ventilations is tachypnoea, more than 35 respiratory movement per minute, assessment or a coma, cyanosis or a cellular complexions, the participations of axillary musculature in breathing on the background of marked dyspnoea and hyperventilations, tachycardia or bradycardia, pupils dilatations. Evaluations of hemodynamics. In the presence of great number of injured persons, one can approximately determine the level of arterial pressure by means of pulse. If pulse is felt on the radial artery, arterial pressure if higher than 80 mm per mercury. If pulse is felt only on the carotid artery, arterial pressure is higher than 60 mm per mercury. The volume of blood loss on the way to hospital may be determined according to shock index algorithm. Shock index is the relations of pulse rate to the value of systolic arterial pressure. In normal, it is half unit. Its subsequent increasing at 0.1 corresponds to the loss of blood in volume of 0.2 liters or 4% of circulation's blood volume. Mistake to the side of decreasing blood loss composed 15%, but it should not used in case of slow bleeding. What you know types of bleeding, of degree of bleeding? It's 4 degree. First, slow bleeding, not more than 5 milliliter per minute. If patients have blood loss 30 milliliter per minute, it's middle bleeding. If 15, it's severe of bleeding degree. If patient blood loss 100 and more milliliter per minute, its definitions perfusions bleeding. If perfusions bleeding, it's very increased danger to life. You very fast must make arrest of bleeding or a tourniquet or embolization tourniquet, or if it's operative treatment, put forceps on vessels. Determinations of blood loss volume according to the shock index by Algover. You look, if shock index half to 1 unit, it's first degree. Blood loss 10% of volume or a half liters, 500 milliliters of blood. If 1 unit to not more than 1.5, it's secondary degree. It's 20% or a 1 liters of blood loss. If more, 1.5, difference you look on its table 1.3, 1.4 and more, it's 30% at 50-100 milliliters of blood. If more than 1.5, it's third degree, but it's terminal phase of shock. Table method of evaluations of blood loss. It's very important on accident place or on admitted department. Why you not have analysis, but you know what have damage, collimetry of trauma. You look, if patient have severe chest trauma, if 50-100 milliliter of blood loss. If traumatic amputations of leg, it's 50-100 milliliter too. Fracture of pelvic, or a 500 to 3 liters. It's if patient have avulsions types, it's 500 milliliter of blood loss. If damage by malgenium, it's maximum 2, 3 and maybe more blood liters of blood loss. If patient have closed femurs fracture, patient blood loss 1 liters. If fracture of ankle, it's 600 milliliter of blood loss. Close fracture of arm, 5 milliliter of blood loss. Forearm, it's 500 milliliter. Spine injury of pelvic. If avulsions type, it's 500 milliliters. If more, it's 2 liters. Threshold of death is not defined according to blood loss volume, but it is defined according to the number of circulations erythrocytes. Critical reserve present 30% of globular volume, for plasma 70%. The organism may survive after loss of 2 or 3 part erythrocyte volume, but death may occur in cause of loss of 1 or 3 part plasma volume. On what case patients lose more not erythrocytes, patient lose less. It's to damage or a burns or a crash syndrome. Normal volume of circulations blood in male is 66 milliliter per kilogram, in female 60.5 milliliter per kilogram. Evaluations of neurological status. Evaluations of sense organs may be carried by means of Glasgow Cone Scale, very old but very effective scale. It's 1977 years. First, opening of the eyes, 3 for vowels, to speech 3, to pain 2, absent 1. Verbal reactions. I joke, it's what students answer on exam. If orientated 5 vowels, scrambled speech 4 vowels, inadequate speech 3 vowels, intra-articulate sounds 2 vowels, answer is absent 1 vowels. Motor reactions. Normal free movements 6 vowels, reactions to pain 5, normal flexions 4, abnormal flexions 3, Extensions to pain 2, reactions is absent 1. After summarized marks, if patient have for 15 points, it's clear consciousness. 13, 14 points, it's stupor. 9, 12 points, sopor. 4, 8 points, coma. Examinations of external injuries and quantitative evaluations of severity of local traumas, colorimetry of traumas. Prognosis of survival is determined according to different formula, nomograms, trauma score, mortality predictions model, or a multiple system organ failure scoring system. During the pre-hospital period, the most evaluations of prognosis is carried according to criteria T based on the scale T-Sibin, the scale of Calberts and other authors. The model number 1, Pashkovsky and other authors, and criteria N, a live or a dead, and also the scale cramps, circulations, respiratory, abdominal, motor, speech. Now have different systems. It's Apache 1, 2, and other. Standard of rendering doctors' assistance in polytrauma at pre-hospital stage. To provide permeability of respiratory ways to evaluate degree of respiratory insufficiency. To determine indications for cardiopulmonary resuscitations. They evaluate hemodynamics. To put a patient horizontally with a lifted lower extremity in cause of bleeding. Its definitions: dry hemotransfusions. If you lift lower extremity, maybe shift volume of blood to lymph-important organs on volume 1 on 1.5 liters. If you lift upper extremity, it's maybe half to 1 liters shift to lymph-important organs. To provide temporary stopping of bleeding. Putting of compressed bandage in venous bleeding, tourniquet or clamps on vessels in arterial bleeding. You look, it's anti-shock costume Kashtan. It's a Russian costume. Have on different countries: German, France, United States, Japan and Israel. Different anti-shock costume. It's very effective. Why? Patients lie on hard surface. It's a stretcher, and plus it's very important if patient have damage vertebra and pelvic and extremity. Next, immobilizations. Immobilizations, you look, pneuma splint. If you pump, you may be not only made immobilizations and arrest on bleeding. And if patient have fracture on thigh, patients not have damage, loss blood only 1 liters. Very decrease its volume. But it's important not on extremity, it's very important on pelvic and abdominal. If patient have close trauma of abdominal organs, rupture, spleen, HEPA, and other organ bowels damage, and you on its spleen increase pressure on systolic of patients, you arrest of bleeding and have increased time. For example, if patient have fracture spleen and HEPA, patient have 15-20 minutes. If you made its anti-shock costume, you have maybe 1-2 hours. Next step, to put occlusive dressing. In open pneumothorax, to make a pleural puncture in tense pneumothorax. If patient have open pneumothorax, you must shift to closed pneumothorax. If you put occlusive bandage. It's hermetic bandage. If patient have tense pneumothorax, you obligatory must shift to open pneumothorax. To provide approach to the vein, to catheterize peripheral vein if there is a special skill with a firm fixations, to perform infusion therapy. It's obligatory after arrest of bleeding. Why? Patients lost more what you made transfusions. First moments, it's anti-shock measures. You arrest of bleeding. Secondary, start infusions therapy. Next step, to give anesthesia by means of introductions of narcotics, anarcotics, analgesics, inhalated anesthetics. Comatose conditions does not prevent pacing of painful impulses. That's why anesthesia is obligatory. On what case you introduce narcotics, on what case you introduce not narcotics. If it's town, you not introduce narcotics. If patient have trauma very far, maybe on mountain, forest, very long time to transport, bad road, or helicopters, you obligatory must introduce narcotics. And if transport more than 1 hours, patients. Comatose conditions does not prevent passing of painful impulses. That's why anesthesia is obligatory. Next, putting aseptic dressing on wounds. Next step, transport immobilizations. In what case you must make transport immobilizations? 4 indications. First, fractures. If you don't know have fracture or not fracture, you must make transport immobilizations. After admitted patients at hospital, you may make X-ray control or remove immobilizations or made treatment immobilizations. But transport immobilizations obligatory. Next indications: damage soft tissue, included accident wounds, burns, frostbites, crash syndrome. Indications number 3. It's damage of joints. Dislocations included indications for transport immobilizations. And last indications for transport immobilizations, it's magistral damage, magistral vessels and nerves. If you apply tourniquet, you obligatory must make transport immobilizations. Only after transportations of injured persons to medical institutions, rendering symptomatic therapy on the way to hospital. When you look on its pictures, it's a special joke painter. Why? Doctors not sit down near driver and look on road. Patients must control of patients and make symptomatic therapy. The drawing made by Professor Alexander Bliskunov are used in the lecture. Thank you. You have questions? If you have questions, write. I answer. I wait. Not have right. Not have questions. If you not have questions, good luck. Finish lectures.